A very good morning to all of you, and welcome to this first session of the ASVS, which is very special. I think at least it's my first time to be here, and I'm very grateful to the organizers to be allowed to moderate the first session together with my co-moderator, Professor Fu from Shanghai. We will have the first session on aortoiliac occlusive disease, meaning that we have several presentations of 8 minutes, which will be followed by 5 minutes of a discussion. However, our first presenter will cover 2 topics, so she will be able to talk for 16 minutes and then have a lengthy discussion. Also, a warm welcome to all our panelists, and I'm looking forward to a very interesting and teaching session. So can I invite to the podium Catherine McGinnigal from the United States to provide us some teaching on endovascular versus open surgery in severe occlusive aortoiliac disease and open and percutaneous atherothrombectomy for iliac CTOs. Thank you very much.
Thank you very much, and I would just like to reiterate what he said. This is my first time to the Asian SVS meeting, and it is an absolute honor to be here. I really enjoy the opportunity to be able to meet so many new people and hopefully gain many new perspectives from each of you. And I'm honored to be able to have a little more time to tell you my thoughts, and do encourage many questions during the discussion. I was initially tasked with speaking about an update in the evidence for aortoiliac occlusive disease. And when I did a search, honestly, there's just not very good new evidence. And so I asked if I could really focus in on this topic and show you some of the evidence that has been the most impactful to me over my career. And hopefully this will be interesting and you'll learn a thing or two. And so I have a few disclosures. None of them are relevant to this talk, but I would also like to highlight the American Limb Preservation Society. It is with their support that I am here. I am in the board of directors of this society, and a lot of what I say will be influenced by the people around the world that I've been able to network with on account of this society. And if you'd like to join us, we always have a meeting in Anaheim, so not too far to get to for you. And there's a big social networking platform to connect yourself with other vascular surgeons and podiatrists and specialists in general. So, open reconstruction. I have a suspicion that, like the United States, most of you in the room do mostly endovascular reconstruction for aortoiliac disease. We've known for years that the patency rates are really quite good. And of course, as with everything in vascular surgery, we shifted to more minimally invasive endovascular techniques. However, open reconstruction still plays a role, I think, in my practice certainly, and for all of us. And there has not really been a lot of innovation in what we do. There's debate about, is a retroperitoneal or a transabdominal approach the best? Like, it turns out whichever one you're good at is the best one to do. Should we do an end-to-end versus an end-to-side proximal anastomosis? There's pros and cons to each one. And so there's not a whole lot of technical innovation in open reconstruction. But the first thing that I would like to highlight is this concept called ERAS. And ERAS stands for Enhanced Recovery After Surgery. It is kind of a nice combination of your individual expertise as a clinician and being able to make a decision about the best operation for the patient who's sitting in front of you. That is guideline-based and using the best external evidence, and then also kind of includes the patients and what they say their values are and what they're going to be able to do for postoperative recovery. And so it's not just the surgeons, though, who are doing this, it's really all of us. It's the nurses, the physiotherapists, the anesthesia teams. And so you get this comprehensive perioperative care pathway that synergizes everybody's best evidence-based practices and aligns them. And so all of a sudden, everybody's moving in the same direction and knows the job that they're supposed to do when they interact with your complex open aortic patient, and that reduces the surgical stress. Certainly the psychological stress for the patient, but more importantly, the physiologic stress. I would like to note that this concept was first published in the 90s, In the 1990s, we were innovating endovascular surgery, and so we spent all of our effort reducing surgical stress by shifting open to endovascular techniques. And quite frankly, we just kind of missed this concept. All of the other general surgical specialties have been developing ways to reduce the stress of open surgery, and as of a couple of years ago, I was very honored to be able to chair the guidelines writing group between the American SVS and the European SVS to create ERAS guidelines for open aortic surgery. It is almost time to renew these guidelines, and I would absolutely love it if some of you from the Asian SVS would join me. It's one of my ulterior motives to recruit some of you to work on this with us, and I think that would really make everything more robust, to have more perspectives. This is a QR code to the guidelines, so you can read them yourself. I'm not going to belabor them much, but I'm going to give you a few highlights. One of the big keys that's different from what I had done in my practice when I first started out is the intense amount of risk factor screening. We all have cardiac risk factor calculators, and this is something that I thought was kind of risk factor screening, right? You have a high-risk patient who's going to get a high-risk surgery. Maybe they see cardiology for clearance ahead of time. But really, you need to take the time to think about, are they anemic and why? Do they have nutritional deficiencies, and can we correct them ahead of surgery? Are they frail? Yes, of course, all of our patients are frail, but what are you specifically going to do in the hospital to help their recovery despite their frailty? What is their delirium risk? What's their mental status exam preoperatively, and how can we prevent post-op delirium, which we know is associated with increased mortality? Force them to quit smoking a month before surgery so they don't have pulmonary complications after being intubated for anesthesia. And then finally, after all of that, assess their medical risk. And in this is a lot of the concept of prehabilitation. Just have a variety of different techniques that helps balance out their use of pressors and fluids and the way that they monitor patients and the types of anesthetics they use. And all of that combined with kind of pre-op optimization means that post-operatively we don't have a lot of the issues that we're used to having, like ileus, delayed return of bowel function, uncontrolled pain that causes them to be sleepy and unable to get out of bed. Everything goes a lot more smoothly. And so there's a lot of new concepts for us that feel very uncomfortable, but there's been many, many series out of Germany and Italy with over 1,000 patients going open aortic surgery that have shown that these guidelines are possible to follow and safely. And so avoid NG tubes. Let people eat when they feel like eating, even if they a case example, my tips and tricks for how I use ERAS. This is a 70-year-old woman who has a history of hypertension, hyperlipidemia, type 2 diabetes, coronary artery disease. She's already had coronary bypass surgery. She's a smoker and has COPD. She comes to my clinic saying both of her legs give out with any walking at all. And after about 10 minutes of slow walking, her calves are throbbing and numb. Okay. She's got dependent rubor, she's got monophasic signals, obviously she's got pretty severe aortoocclusive disease. This is somebody who's called not a good operative candidate. And so immediately I'm thinking to myself, fantastic, let's come up with a way to do an endovascular repair. Except when you take a look at her scans, she's got a really included, and she finally reconstitutes at her femorals. And so there has to be at least a few millimeters of space, otherwise I'm worried about jeopardizing the renal arteries. Maybe some of you are more aggressive, but in her, I decided she needed to get an aortobiofem. The case went pretty smoothly. It took me about 3.5 hours. She had a supraciliac clamp that was on for about 12 minutes. I used Cell Saver to give her back some of her blood, and it was very, very smooth. And so out of the operating room, this 70-year-old woman with all these comorbidities, she went to our step-down unit, not the critical care unit. She had an epidural in place, it worked, she didn't have any pain. She wasn't fluid overloaded. It was a pretty quick case, and she didn't get too much fluid in the OR, so she didn't have an ileus. Therefore, she didn't need an NG tube. She felt thirsty. Her mouth was dry, like they always are, so she got some clear liquids to sip on. I gave her a low dose of IV fluids, and she got up to the chair that first night. She did really well. The next day, her arterial line came out. She was making good urine. Her urinary catheter came out. I medlocked her. She felt like eating, so I let her eat whatever she felt like, and she was able to get out of the bed with the nurses and walk around. The next day, we changed her just to regular hospital floor status. She was eating normally. She didn't have any bloating at all, and her epidural was discontinued. She went out with physiotherapy to walk in the hallways. That gave her the confidence to walk alone with her cane in the hallways the next day, and she went home. And I don't give this to you as an example of what a miracle patient can do, but what happens pretty routinely when I do an aortobifem in my hospital now. This is not the experience that I had in the first half of my career before I really leaned into ERS. So, I still do mostly endovascular surgery though, and so endovascular tips and tricks. The main thing that I think about for aorto-occlusive disease when I'm doing an endovascular approach is what am I going to have to do after this? And so more and more frequently, people with aortoiliac occlusive disease also have infrainguinal disease. And kissing iliac stents and covered endovascular repairs, which is basically kissing iliac stents up into a covered aortic cuff, alter the aortic bifurcation, and they raise the bifurcation. And so it makes it much harder to go up and over to do lower extremity interventions in the future. And so based on what I think is going to happen over the patient's lifetime, I have really moved to preferring to using the Endologix aneurysm device, the AFX, to do aortic reconstruction endovascularly. So the AFX device is a unibody design. It's a 17 French main body. It's designed for aneurysms. Frankly, it doesn't work so well for aneurysms. There's other better things on the market. Part of the things that's challenging is it's got this external PTFE that's not completely incorporated with the metal stents on the inside. And so there's some nuances. In occlusive disease, especially with small iliacs and occluded iliacs, you really need to get a good predilation to be able to get the device up. Once you get it up, you can pull it down on the bifurcation, which is the real pro to using this. You have to avoid getting stuck behind the struts, and the limbs were not made for occlusive disease or any kind of heavy calcium, and so they often don't expand, and even if they do expand, they don't stay expanded well in the long term. But it was this. This is a hospital that's within my healthcare system, about 30 minutes away from me. They really started to innovate using this device, and it's this paper that's been published, which is the other kind of important update in the literature, I believe, that's influenced my practice. And it's their 10-year experience of over 100 patients using this device for pretty severe aortic occlusive disease. In the United States, there's slightly more of this disease in women who have been smokers, and that was reflected here in their demographic table, and they had all of the standard comorbidities you would expect. Most of these were done for claudication. We tend to get kind of the sicker, more serious ones in the university hospital. But still, they had a good 30% or so that had CLTI. And noticeably here in the orange, over half of the people had really long segmentasti lesions. So similar to the 70-year-old woman that I wish I did endovascular surgery on, perhaps, that I just showed you. As would be expected, when you restore inflow to a patient's legs, they feel better. Their Rutherford class improves. They did measure clinical improvement and found it, and they had really remarkable patency rates. Primary patency was 86% at 5 years, which is pretty similar to open aorta bifems, and their secondary patency rates were almost 100%. So with this, we started to get more aggressive with selecting AFX. And so here's a case of mine. This is a 72-year-old man. He had short distance claudication. Right leg was worse than the left. You can see here he had bilateral common iliac disease with an occlusion on the right and some stenosis on the left. He also had left common femoral disease that needed an endarterectomy. So I brought him to the operating room. and was able to get wires up both sides, staying in true lumen, which you can see here on this initial angiogram. Here is the stent deployment. You can see the aortic body opened up nicely, as you would expect, because the aorta was pretty healthy. But on the right side that was occluded, the iliac limbs then expanded, despite doing a balloon predilation to that occluded area. And so what I have done over time and getting more experience with this is that once I deployed the device, I use balloon expandable metal stents in the common iliacs, and that just provides more radial force and helps the device stay open longer. And then, depending on what the extent of the external iliac disease is, just do self-expanding metal stents all the way down. And in the end, he had a pretty good result, and this worked well. And it preserves the bifurcation in the event that I need to go back to fix, femoral or infrapopliteal disease later. So, in summary, if you're going to do open surgery, I would highly encourage you to use ERAS if you are not already. It really improves the patient experience and outcomes. It also just makes it much more pleasant to work with all of your colleagues. Even in high volume aortic centers, we don't do that many open aortic cases compared to, say, liver surgeons or colorectal surgeons. And so everybody is a little bit stressed when we bring in open aorta to the operating room. And if they can work on a pathway, they're happier and they communicate better, and everything is just better. And I like the endologics for aortoiliac endovascular reconstruction. Seems to be effective and durable, but it is not a purposeful device. And so if any of you are working with endologics, I would really love to see a lower profile, hydrophilic coating to make crossing through occlusions easier, more radial force in those iliac components especially, and the fused structure and fabric system. So with that, thank you very much for your attention, and I welcome any questions.
Yeah, please stay with us for a second, Catherine. There's a bit of confusion, so I'll look to Dr. Koum, but I was instructed that we have questions straight after each talk. We can do it after, at the end?
No, that's fine. We can do questions.
Yeah? Okay. So we'll do questions now then. And I have a question, or maybe even two. This is because of this is for the AFX device, which I haven't used too often and never for occlusive disease. I agree that it doesn't work so well for aneurysms, but this is a 17 French device. So I don't see many patients that can have this treatment with the 17 French device with aortoiliac disease percutaneously. I saw you were having clamps in the groin as well. So the common femoral is often also diseased somehow in these patients. So do you always combine this with an endarterectomy, or do you always use open exposure? How do you approach this?
Yeah, that's a really good point, and I glossed over it a little bit. In this particular case, it was his left iliac system that was better, and so I chose that side to get the 17 French up, but he had an occlusion in his left common femoral. And so I cut down, did the femoral endarterectomy, then inserted the 17 French. Sometimes if they just have like posterior plaque in the common femoral, I'll cut down, and before opening the artery, access with a needle, insert the sheath, and do the case, and then on the way out, do the endarterectomy. And sometimes, if the person happens to just have small blood vessels, it's too big to get a 17 French up, but I try, and I do it, just with sequential kind of balloon dilation to see if I can pre-dilate to get that 17 French up.
Okay. Just another quick question on the AFX. What's the length of the body? I think it's probably around 4 centimeters.
Yeah, so that the aortic unibody, I think, is 3 centimeters. And they have a cuff to extend up if you would like to. And so if you have like a longer segment, like task D aortic involvement, you can potentially still use this device. The other thing to think about is where the IMA is in relationship to where that cuff is going to be, and if there's any large lumbars that provide collateral circulation. In this case, he had really big lumbars, and I covered them. But hopefully he doesn't need that collateral system after you open up the aortoiliac system.
Great, thanks. We have a question from the floor.
This might be an odd question, but I wonder, because the bare metal stents and the covered stents patency differs, if you need to put a bare metal stent in the iliac extension, do you do it prior to advancing the unibody graft, or after putting it and seeing it's not opening well, you put the bare metal inside the AFX? Or before deploying the AFX? That's
an excellent question, and I've actually evolved in the way that I approach this. And so initially, because oftentimes you do a lot of predilation to even get the sheath up on the main body side, the graft will open up really nicely on that side. And then I would just post-dilate with a balloon the contralateral limb. And I noticed that if I were going to have a patency problem, it was usually with one of those limbs. And I think that's just because it just has really terrible radial force. And if I got, perfect expansion in that, few seconds it took me to take the picture, it didn't last. And so now, no matter what, I deploy the device, so then you're protected by the covered endograft. And then I do balloon expandable bare metal stents, just because you already have the PTFE and the benefit of the patency of the covered graft, plus the safety of the covered graft, so you don't have to worry about a rupture. And I put the bare metal stents in on both sides every time.
Okay, thank you, Catherine.
Thank you very much.
Excellent presentation. Now we move to the next speaker from Australia, Robert Frederick. His topic is the open surgical strategies for the AIOD, essential technique and pills. Welcome, please.
Thanks very much for the invitation to speak at the conference, and it's a bit of a hard act to follow, Catherine, but we'll give it a crack. I'm presenting this on behalf of myself and Albert Coda, who's a vascular surgeon, has been working with us for a couple of years, trained in Vellore, and he's a great colleague. So I'll just talk about indications for reconstruction, imaging modalities, surgical options, current evidence, the AVA, or Australasian Vascular Audit data, and conclusions. I've got no disclosures. And I guess you're all familiar with the TAS classification. And I've just put it up there, though, just to remind ourselves. But basically, if you're considering open intervention, it's almost certainly going to be TAS-C and often mostly TAS-D lesions, as you can see there in the bottom corner. A lot of patients are treated for disabling claudication, but CLTI is obviously most of what we do, and a lot of centres do, but it just will depend on your practice. A lot of the patients we're treating have had failed endovascular therapy, and I would say the vast majority of the open interventions, in my practice anyway, have had one or more, sometimes multiple endovascular procedures over a period of time, which may be short or long, but they've run out of endovascular options. Often early recurrence after endovascular intervention, and patients with moderate to severe CKD, where you're going to be consider using a lot of contrast, you might swing towards an open repair to avoid contrast-induced nephropathy. So what are the surgical options? Well, I guess when I was training, we did a fair bit of aortoiliac endarterectomy, but that's extremely rare now, and probably done very rarely when you've got an incredibly calcified aorta that you think you're going to rupture with a stent. Aortoiliac or femoral bypass, and occasionally we still do thoracic aorta to femoral bypasses, but that's once again extremely rare in contemporary practice, but is probably the best open option in most TAS-CD lesions. Extra-anatomical bypass, which can be iliofemoral crossovers or AX by FEM, and I'll talk a little bit about AX by FEM because that's actually something that we do relatively frequently. particularly for CLTI and limb salvage, and of course hybrid procedures. So that may be something like, endarterectomy of the femoral artery, an iliac stenting, or it may be much more complex, and certainly some patients with extensive tissue loss, you really want to get inline flow to the foot, so you really need to deal with multiple levels of disease. So imaging, I think our go-to imaging is CT angiography, and I think most people that's the case. I think in this aortoiliac disease, it's really quite important, partly for where the occlusions are, but also the degree of calcification, and I think that does determine your approach quite often. MRA is actually very useful in terms of level of occlusive disease, etc., but it doesn't give you a good feel for the amount of calcification present. So we don't have as ready access to MR angiography, but I think we kind of appreciate knowing how much calcium's present in terms of making our decisions. As Catherine said, I think we have a lot of patients, well, relatively frequently, that occlude just below their renal arteries, and we don't really think that's a great, safe endovascular approach. So a lot of our patients either need clamps just below the renal arteries or suprarenal clamping, at least while you're doing the endarterectomy, to make sure you don't trash the kidneys. Seaman looked at the VQI from 2009 to 2021 and looked at trends year by year in terms of aorta bifemoral versus CRAB. I don't think this includes standard iliac stenting, and I think in most people's practice, routine iliac stenting would form 80 to 90% of their practice. But you can see that from 2009 to 2021, aorta bifem went from 100% of complex lesions to 80%, and CRAB went from 0 to 20%, and I suspect that trend is continuing in the same way over the last few years. What are the differences in terms of morbidity, etc., after aorta bifem versus CRAB? So in that VQI series, the length of stay was 7 days versus 1 with aorta bifem. Pulmonary complications quite high, renal complications about 10%, and major adverse cardiovascular events 12% with aorta bifem versus 1 to 2% with CRAB. So obviously CRAB's a very attractive option for most patients, and you can see the survival in terms of male-free survival estimates, that overall the aorta bifemoral bypass had much superior male-free survival rates compared to CRAB. And obviously, if you have single centres with a lot of experience, they'll probably get better results than over the VQI generally. What are the long-term outcomes of open revasc for complex aortoiliac occlusive disease? So this series had looked at TAS-D lesions in 2 centres in the UK and Switzerland, and surprisingly, actually, acute and chronic outcomes were essentially very similar, but survival over 4 to 7 years was better with the elective patients versus the emergency patients, and most of those deaths occurred after the first year, which is kind of surprising, I guess. But and then Zarantan looked at midterm outcomes for aorta bifem, AXFEM, and CRAB, and that's using the VQI from 2013 to 2019. And you can see that in blues, the CRAB freedom from re-intervention, which was there was more patients having interventions with that than AXFEM or aorta bifem, which I find actually rather surprising, because certainly in our practice, AX bifem seem to require interventions reasonably frequently. It might be the indications in CLTI, you have runoff problems, so your patency's reduced, which that's what I blame anyway. I'm not quite sure. Maybe it's just me. But and limb salvage was best with aorta bifemoral bypass, but the other 2 options had still excellent limb salvage rates. And overall survival was worst for AX bifem and best for aorta bifem with CRAB in the middle. And I think that really just reflects the indications for intervention and the sort of health of the patients. But you can see that the survival wasn't that great out to 3 years. So we looked at the AVA, or Australasian vascular audit data, which is data submitted in Australia and New Zealand from 2015 to 2024. I excluded standard iliac stenting and it was quite hard to sort of separate iliac stenting from CRAB. So I'm just here talking about aortofemoral and aortoiliac open versus axillofemoral bypass. And if you look at the patients undergoing aortofemoral, quite a small group were for infection, and I've excluded them from the rest of the analysis. But you can see the average age was around 60 over that period of time. average ASA was under 3, so a relatively select group of patients in most of our practice. Quite a high proportion actually for claudication and about the same numbers for CLTI. The mortality was 1.5% to 4%, and the length of stay was quite long. So we obviously need to learn from Catherine about getting our patients fixed and out of hospital. So we might talk to her afterwards. And in terms of axillary bifemoral bypass, you can see the average age was 8 years older than those having aorta bifemoral bypass, and the ASA average was well over 3. And once again, excluding the infection cohort, mostly the patients were treated for acute ischemia or CLTI, and the mortality was between 7.4% and 10%. So that's really quite dramatically different outcomes in our patients across Australia and New Zealand. And I don't think that is entirely surprising, but I wasn't expecting it to be quite as dramatic a difference between those two groups. So in conclusion, I think open aortofemoral reconstruction still has a significant role in lower limb revascularisation. It's got excellent patency and limb salvage in appropriate cases. I think we use it mostly when endovascular reconstruction is not feasible or has failed. Extra-anatomical reconstruction, particularly AXFEM, has an important role in limb salvage in older and sicker patients. Protecting renal arteries in juxtarenal occlusive disease is important, and the renals may need temporary clamping, which we tend not to do with aneurysm repair. We use a lot, well I do anyway, a lot of sartorius flaps in the groin because we have a lot of patients who are having redo groins. They've either had a groin infection or significant sepsis or really extremely overweight. And I think it's something to always think about. I mean, I don't think you need to do it every time, but we do a lot more sartorius flaps now than we ever did a few years ago. And I'd just like to thank Barry Bayliss, who runs the Australasian Vascular Audit. So thanks very much.
Thank you, Robert. Is there any question or comments for the panel? I have a question for you. If the occlusion limb is just renal arteries, how do you deal with the proximal anastomosis?
Yeah, so I think there's different options, but if it's occluded up to the renal arteries and the renals are okay, generally we'd sling the renals, suprarenal clamp, do the endarterectomy, and then ideally clamp below the renals if possible, and do the top anastomosis. And I think that's what Catherine was talking about doing because, 12 or 13 minute ischemia time, usually that's what you would do. But sometimes we do an endocide that goes across the renal arteries, across the level of the renal arteries into the suprarenal aorta. I don't think there's one approach that fits all, but that would be the two most common approaches I would use.
Yeah. Thank you. Yeah. Okay, please.
Yes. I noticed that you have several infection cases in your open surgery group. So my question is where infection coming from? Is the groin femoral or the graft in the abdominal? So when we do the open surgery for the aorta bifemoral bypass, so the graft actually is after the procedure is attached to the duodenal. So have you ever been seeing any graft enteric fistula like that?
There was in the aorta bifem group, there was really a very small number, and The indication on the audit is, what's the indication? It says infection, but with ACTS by FEM, there was quite a high proportion. So they'd be patients with infected aortic grafts usually, or aortoenteric fistulas. So I would say the vast majority of the intra-abdominal sepsis that need aortic reconstruction would be fixed with an ACTS FEM or ACTS by FEM graft, if that's what you're asking, I think.
Okay, thank you.
Rob, thanks.
Yeah. Go.
Oh, sorry. Rob, thanks for the talk. I really enjoyed it. Could you give us an idea of how would you open someone with an occluded aorta by FEM graft? Can you do it endo? Is it native going through the bypass again, or
Yeah,
what's your
we normally would open the bypass, usually on both sides. I guess it's a customised approach, because sometimes it's one limb that's occluded, and you might decide to just do a crossover graft, or it partly depends whether it's early or late, but we tend to open the groins and try and clear it through the groin. Often have to re-stent it.
So you have to reline it because a lot of gun
Yeah,
within and
yeah,
run a FEM
yeah.
or something
Actually,
like
years
that.
ago we started doing angioscopy, and it was
Right.
the most horrifying, because I was doing a lot of the transplants and renal access, and when you go up there and you look what's in there, it's horrifying. So, but I think sometimes if it's early, you can thrombectomise it, fine. The technical problem might be a kink in the graft as they lengthen or something like that. But
And how about going native again? Could you go, because a lot of the aorta biFEMs, they last a long time. They were
Yeah.
done quite a long time ago.
Yeah.
And could you go native, and have you done that? And any tricks on
Native?
going back on the regular endo for the native aorta?
Oh, yeah. It's. I actually had a couple of years ago that had been put in, 20 or 30 years ago, and I had to take out the graft, and the patient had a pulse at the end of the procedure. So the native vessels were actually quite good, but it was just, years ago people they were doing it for relatively minor iliac disease, but certainly trying to recanalise the iliac arteries and the aorta is a good option, and we would do that, if we can, that's for sure.
Thanks.
Has doing endo first ever sort of knocked off, run off, or made open surgery impossible? My experience, it hasn't. It just blocks and you go back to option B. I don't think you lose a lot by doing endo first in these situations.
Yeah, I think sometimes the groin gets somewhat unattractive if, I think the hybrid ones where you've done a femoral endarterectomy and iliac stenting, that's obviously makes it harder, and they're the ones that sometimes you decide to do a sartorius flap, but purely percutaneous, which I think was what you're talking about, I don't think it affects or compromises your next intervention pretty much ever.
Yep. Thank you very much, Rob. So now we welcome Professor Frans Mol from the Netherlands, who has spent a lot of time of his career working on the concept of remote endarterectomy. And we had a nice discussion about that already last night. And I'm really looking forward to a presentation from Mr. Remote Endarterectomy, Frans.
Thank you very much, Mr. Chairman, and thank you for the invitation, Congress Committee. It's a great pleasure and honor to be here again at the ASVS in Singapore. Last time was 2016, in Singapore at least. So the recent global recognitions in peer review journals, apparently it's still going around, both in the US, but also in Russia and in Asia. So that's probably the reason that the organizing committee asked me to address this topic again. The summary of the latest publications are remote iliac endarterectomy by a single groin incision is safe. A minimal invasive and no prosthetic materials, no anastomosis. General, spinal, or local anesthesia is up to the surgeon in charge, and the internal iliac is usually not bypassed. So you preserve that if it's still open. Useful to remove the infected stent graft, remove calcified intima core for better anastomosis in kidney transplantation procedures have been addressed in the several publications. and also allows simultaneous distal or crural interventions through the same groin incision. This is the incision, just an example, and a schedule. People know this at around the level of the deep femoral, the profunda. You can also do a profundoplasty if applicable. These are the instruments that usually are being used. Vollmar was in the 70s in Heidelberg the king of endarterectomy. And these are still available, these Vollmar rings, and they are reusable. So with the green mentality of the moment, it's another plus. You don't throw away. And this is how it is being entered. And so what I used is the Vollmar ring in the beginning for total occlusion, and then the ring cutter. The rings are oval in a 60-degree angulation to the shaft, and they act like a pair of scissors, very sharp at the inside. So you cut the intima core and take it out gradually. The technique, I mentioned already the groin incision. I like under fluoro, so make some landmarks and do it retrograde. Complete removal of the intima core, and you can, of course, address also an endarterectomy of the common femoral artery bifurcation, profundoplasty, if you think this is applicable, as mentioned before. This is an example what you get to take out. My preference is a total occlusion, not just stenosis, and the other things I mentioned already. So here you see an incision in the right groin. You bring up the ring cutter, you cut the intima core, and this is how it is artistically drawing. And here you can see a control angiography, and my preference is usually an approach from the other side over the bifurcation, if possible, if that is occluded, or otherwise you can, of course, use the same incision, but you have to check it. You can also do to see it visually, but you will be horrified after an endarterectomy about the surface. Anyway, remote endarterectomy for the iliac occlusive disease. These are some results, but in the literature there are plenty of others. So the problem is, what is it still after 5 years? And I think in this case you can also speak about the primary assisted patency. I know that this is lacking some popularity, but on the other hand, if it is a minimal procedure to enhance the patency, it's not bad at all, and you almost approach the 90%. So it's still a method that you should have in your armamentarium as a vascular surgeon, in my view. And this shows you the patients with the number at risk during follow-up. And that's also not very bad, specifically if you look at the primary assisted. So in conclusion, Mr. Chairman and ladies and gentlemen, I rush a little bit through your program to gain some time, because you were running late a little bit. Remote endarterectomy, I think by a single groin incision is safe. It's still minimal invasive and no prosthetic materials. It's reusable in the green wave at the moment. General spinal or local anesthesia to your preference and condition of the patient. Usually the internal iliac artery is not bypassed. It's useful to remove an infected stent. I've done this several times, and the team as well. Remove calcified intima core for better anastomosis in kidney transplantation. My colleague from Australia just mentioned that he is in charge of kidney transplantation, and I think a remote endarterectomy, we did it several times. Also, our clinic is certified to do kidney transplantation, and it's very useful. And it allows simultaneous distal femoral crural interventions through the same incision. So what is the outlook for remote endarterectomy for occlusive disease? I think it should be a reappraisal, because recent progress in the clinical research with biopharmacological suppression of restenosis after endarterectomy was not available at the time of Vollmar, but it's now available. So why not combine it if necessary, not immediately as a primary tool to increase the use of stents, but selectively and specifically the new ones are just justified to use. So my choice and message would first an endarterectomy through a single groin incision and consider the more modern biopharmacological suppression of restenosis, and I thank you for your attention.
We have a question from the floor, please. It's interesting with all those delegates from different countries to hear who's asking the questions. So please state your name and where you're from.
Yeah, thank you, friends. I'm Matthew Sebastian from Newcastle in Australia. We've met a few times.
Yes.
I've certainly had experience with using it in native disease, but I've always been interested in the removal of stents, especially since now since the COBEST trial reported, was it 12, 15 years ago or something like that, we're using a lot more PTFE stents in the iliac segment, and we are seeing the odd infection. And it's a total disaster for some of those patients. And I think if we could use this technique to get the stent out, that would be great. But how do you do that?
You mean
the exact same technique?
Yes. The only thing
I've never been able to get past that that interface in the stented segment. Native, yes, but
no, you have to go beyond the stent,
Yeah.
in the surface, in the layer of the media. You go beyond the intima actually. In that section, you're never sure whether it's still a piece of media or the intima, and you will probably lose a little bit more blood if you do it only with a groin incision. So it might sometimes be of help to go from the other groin percutaneously and do a balloon occlusion in the common iliac above the infected stent to have the time. But before that, before you start working with such a balloon, just don't use that balloon yet. Just go above the stent, where the stent location is anatomically.
what about in the common iliac, especially if
That's
it's
more
protruding into the
challenging.
aorta?
Yeah, I tried that. I did it several times, but then you are dealing with different diameters.
Yes.
And if you do the approach through a single groin incision, that's not very helpful. Then in such a case, it might be useful to do a retroperitoneal incision on the same side and go retroperitoneal to that common iliac artery and to manipulate and get that stent out. Because I agree with you that it is a disaster when it becomes infected.
Yeah.
It's so difficult to treat. So the future will be also not only that procedure, but also bioabsorbable stents.
Yeah.
Because then you can treat it with antibiotics. So the use of polymer-derived stents is the future instead of the stents who are not absorbable.
Thank you very much for the presentation.
Just put on the mic.
Yeah. After making endarterectomies in the carotid or the common femoral arteries, we sometimes see neointimal hyperplasia, which is progressing super rapid restenosis of the segment. Do you see the same after making an excellent endarterectomy and seeing a severe stenosis in the near future in your follow-ups?
Yeah, that's especially true for the superficial femoral, but the superficial femoral is well known to be difficult to have to create a long-term patency, also with the modern biopharmacological procedures. However, in the iliac, I see less restenosis occurring than in the SFA. SFA is the youngest phylogenetically artery in our body. Animals don't have an SFA, but the bless of the SFA is that it is so difficult to treat this young artery and prevent restenosis. So that brings us for years and years, also in the future, some nice research. The SFA is the most challenging artery in your whole body.
Yeah, Professor Moll, I just have a question. We've done a couple of cases in the femoral artery, but I must say we need to take some liquid courage before we do the iliacs. I always find I'm a bit cautious and a bit worried.
But the surgeon is never afraid.
No, I am.
That was my teacher who said also.
I'll take some lessons from that. But I've always felt that coming up a tortuous iliac coming around could be tricky. And we have tried to use a terumo wire to dissect endovascularly to
Sure.
sort of create a plane before we do that. Is that something that you would do or advise?
Yes.
To remove?
Not to go out of plane.
Not to go out of plane?
Yeah.
Okay.
Yeah.
And
Good advice.
how often would you supplement the remote endarterectomy with a stent or some other adjunctive anti-restenotic, as you mentioned?
Approximately, if you do it in the iliac conduit, approximately it's not often necessary. Depends a little bit on your cutting edge.
Yep.
However, in the SFA, more distally, I use that very often.
To sort of like almost surgically
At the transition zone.
tack the stuff to the side.
Yeah. And now the bioabsorbable stents are becoming available and certified, and that's a big relief.
Mm-hmm.
Because then you don't see that stent anymore after 3 years of follow-up at the distal cutting edge.
And in the, sorry, just I cover so many questions, but in the aortoiliac segment, after you do an endarterectomy, do you ever see, well, let's not say ever, but how often would you get aneurysmatic changes or something along that line? This is a question.
No.
Never.
No.
Okay, great. Thank you.
Unless you have a patient with already a proximal aneurysm,
Yeah.
then you should be afraid about some kind of aneurysm.
Looks like we got to get you in your operating room with us.
Yeah.
Thank you.
Okay, thanks.
So just maybe I'd like to ask the floor, because I would be very curious who uses this technique. Can we see hands who uses this technique? Okay. So
Well, in North Carolina, they are using it.
so this is around 5 people in
It's
the room.
true. I'll say that there's a very high volume center in North Carolina close to where I work has really great results, but I am too nervous.
I included in my presentation. I thought, well, North Carolina, Columbia, that's included. Maybe Catherine will allude it.
Can I just ask one last question? Sorry. As a lot of us young surgeons, we have no experience in doing remote endarterectomy. I was just wondering, if you have a very calcified internal iliac artery and you have occluded common and external, how do you get the ring past the internal iliac artery? Commonly, if we do an open surgery, we've got to use downhill to break the calcium. But if we do a Voma ring endarterectomy, how do you get past it if you have occluded common and external? How do you get past the internal origin to get the ring up, or you can't do that?
Yeah, that depends on the anatomical situation at the moment, but you need the proper instruments,
Okay.
So I think it often breaks at the internal iliac.
Yeah.
So you're never really able to go all the way up to the aorta. So it breaks
No.
at the internal iliac. So
Okay.
you can do this for the external.
Yeah.
Yeah.
And in Holland, still several clinics are doing this, like in Rotterdam, in Maastricht, in Utrecht. We are restarting the procedure because we think that the latest applications of therapy to reduce restenosis is appealing, to give it a rebirth.
How often do you see perforations? Very rarely.
Perforations?
Yeah.
Yeah,
Contagion.
it's a learning curve.
Learning curve. How many cases for the learning curve?
No, well, we did so many demonstrations. We got so many visitors also to our clinic. Perforations with the correct instrumentation are rarely seen.
Yes. Thank you, Professor Morse, for your excellent presentation for us. The next speaker is from the Thailand, Professor Lokapan. Yes, welcome, Professor Lokapan.
Thank you. I will talk about the advanced crossing algorithm and the techniques. I'm from Hat Yai, Songkhla, Thailand. So the aortoiliac segment is involved in about 1/3 of the PAD patients, and the surgical reconstruction is very effective. Lately, the guideline from 2024 shifting for the endovascular technique include the primary stenting and also the balloon angioplasty with the selective stenting. The key challenges is the crossing CTO, and 20 to 50% CTO crossing failure experience related to the experience of the operator. So the consideration for dealing of the CTO in the aortoiliac segment is a preoperative imaging is very important. And mostly we use the CT angiogram. With the new technology of the spectral CT, we can cut off or remove the bone from the soft tissue as well. So you can see the occluded segment and the healthy of the artery, including the preoperative ultrasound to see the healthy of the common femoral artery and also the SFA segment. So our strategy access for the aortoiliac occlusive disease, we use the ipsilateral approach, contralateral crossover, transbrachial, and the bidirectional approach. The choice based on the anatomy and also the occlusion characteristic. I would like to share our 10 years experience in our center about the crossing strategy of the ALD in the 2010 patients. TAS C and D is about 90 patients. This is the baseline characteristic. And the lesion in the TAS C and D, the occlusion length is about 10 cm, and the TAS A and B, the occlusion length about 3.5. We achieved the technical success on the crossing in TAS A and B about almost 100%, and TAS C and D is about 84%. In the TAS C and D, if you use only the unilateral or bifemoral approach, we achieve the success crossing about 89%. If we add the bidirectional, like the femoral and brachial, we can achieve up to 93%. So in TAS C and D, as I told before, is if we add the additional brachial approach, we can achieve from 90% to 93%. And how about the guide-wire selections? In the non-occlusive, we use most of it, the 035 thermal or thermal stiff guide-wire, but the occlusive lesions, we use both, like the 035 and 018. I would like to share about crossover approach for this is the not so difficult. We use the crossover approach from here, advance the crossover supporting sheet, and use the 018 guide wire for crossing the external iliac artery. And then same thing from the crossover maneuver, and this is the result. For the ipsilateral, we start from the 035 or start from 018. In this case, we use the Berthoud catheters with the stiff thermal guide wire. And crossing with the 035 thermal stiff. And doing the kissing stent at the common iliac origin, like the kissing fashion. And this is the result. Sometimes we have we don't have the space or the puncture site from retrograde from the groin, so we use the crossover approach. But sometimes it's the supporting system is not good enough. We do crossover. However, it's in the subtimal plane, so we do the distal puncture at the occluded stent here, and do the balloon angioplasty of the SFA as well, and then doing the stent from the crossover. From the transbrachial, the good thing is we can treat both sides of the disease on the right side and also the stenotic on the left side as well. This is the last choice for the bifurcation occlusions. We use the bilateral axis and also the brachial axis. I follow with the algorithm from Dr. Renan. If the stenotic disease is the occlusion disease involved in the more than 2 centimeters, we use the open surgery or also the CRAP techniques. I would like to share with this case, occlusions distal aorta include the very severe calcified at the common iliac artery and occlusion of the external iliac artery, like this. So we use the bilateral approach, including the left brachial approach. We can cross easily from the right side with the O35 tumoral and the left side we use the 018 V18, and we are in the subintimal plane. So we use the burn catheters and try to use the O18 system to cross from above, but cannot reach to the true lumen, so we change to the CDOY, acetal 40 gram, and then we can achieve to the true lumen, pre-dilate, and doing the CRAP. And this is the final result. Sometimes we face with some rupture, so we need to back up with the stent graft planning. So my take-home message, careful pre-operative procedure imaging and planning is very essential for the ALD CTO. Success is depend on the choosing of the right access strategy and the guide-wire escalations. Mastery of the multiple crossing and the re-entry is improve the technique, and the collaboration with the colleagues is very important. So thank you.
Thank you. Yes, please, Dr. Sun.
Thank you, Professor. I'm Dr. Sun from Taipei Macmillan Hospital. And thank you for your excellent talk. And I have 2 questions. One is, how do you deal with the possible distal invalidation, especially from sometimes the thrombus is very high, and we are not sure the thrombus is mixed or fresh or organized. So how do you prevent that? Do you do the preoperative thrombolysis, or you put some distal protection device, or you just cut down? And my second question is, for me, we face some patients very young, and the patient may be mixed with maybe germ cell aortitis. So how do you deal with this inflammatory artery disease? Thank you.
Thank you for the question. For the first question, we review on the CT scan. So I think CT scan can see some edge of the thrombus if the artery is quite big. So if you saw some thrombus load a lot, I think we plan for the cutout to prevent for the distal embolization. But most of the case we use the percutaneous. We never use the thrombolysis before for the first question. For the young patient, I think we discuss it with the team. I think for the young patient, we go for the surgery. It's better. Yeah.
Thank you.
You have a question? Thanks for the talk, Sir. I've got a couple of situations where the patient's aorta is small and very calcified. So I have a question. Is there a minimum size of the aorta that would influence how you reconstruct? And the second question is the style of reconstruction. Is there a role to put a stent into a uni-iliac and then do a surgical cross or something like that, if the aorta is small?
If aorta is small, like the last case, the common iliac is around 4 or 5 cm. So we use the CRAP. Normally we use the sizing as the 12-8 for the CRAP, but if the common iliac is very small, so I use the small size is 7. I think 6 is acceptable, but too small for the outflow. Yeah.
And for instant occlusion, what is your technique to pass the wire go into the stent and not into beside the stent also?
You mean in the occluded segment
in
for the
aortoiliac
segment? We try to. I start with the workhorse first. Thermo 018 or 014, not for the aortoiliac, but and after it's failed with the workhorse, we use the CTO plasma.
And how do you treat the occluded iliac stent when you've recanalized it? Do you reline or do you progress to a CRAP?
For the occluded
common iliac stent.
I think it depends that if we do look on the CT scan, if there is some thrombus, we use the thrombectomy device, lysis first or thrombectomy for the iliac occlusion. But if the problem is come from the compression, because normally we use the balloon expandable stent, the problem of the reocclude is the compression. Sometimes the patient, Thai people love the massage, and some massage is compressed of the stent. We have 3 cases with occluded stent from the Thai massage.
Oh, yeah?
Yeah, so in this way we rely the new stent. Yeah.
Just to inform everybody, we do have. I'm part of the organizing, but we do have a massage station for. No, I'm not kidding you. I'm really not kidding. We do have a massage station at one of the back of the rooms, and there's one specially for the faculty as well. Just to let you know. But anyway, but I'm quite worried right now if I go to Thailand that they don't reach too deep.
For
yeah, there's actually also a study from Germany with 660 patients enrolled. They compared the 19-hole stents versus the balloon expandable stents for the treatment also of the common iliac artery. And they found that the self-expanding 19-hole stents are better in long-term patency compared to the balloon expandable stents. So that's why also I switched my behavior for the common iliac artery towards the 19-hole stents rather than balloon expandable stents.
Thank you. And what do you think about the steel benches to use for AIOD, and because for decrease the chance of brachial access?
Yeah, that is a good point. I think if we can have some support from the crossover approach with the specific supporting sheet, I think is very good that we can avoid the approach from the brachial to cross the aortic arch. Yeah.
For the lung occlusive disease patient, I think there is some thrombosis in the aorta. So you pass using the wire to the lesion. Do you usually use the debulking technique before casing or place the stent ground?
No.
No? Okay. Thank you. Okay, thank you very much for your explanation for us. So next to speak is the Professor Mies from the Sixth Lab. Welcome, please.
Thank you very much, Mr. Chairman. In this highly interesting session, we go from remote endarterectomy, which exists already for 40 years, maybe 50 years, to something that is really quite novel, doing radiation-free procedures using force technology. These are my disclosures. I would like to show you fiber optic reel-shaped technology. This is a technology that is able to make full-shape 3D device visualization in real time and in distinctive colors. You can see multiple and unrestricted viewing angles, and it uses light instead of X-ray into the LumiGuide guide wire, which is a guide wire that works with regular, compatible, familiar catheters, thanks to a 3D hub, which is attached at the back of the guide wire. And this is a video to show you how you can visualize the guide wire and the catheter. It has an AI-based semi-automatic registration, and it's able also to visualize tight bends, such as a SOS-like catheter. There's quite some experience with endovascular navigation in different aortic procedures using this technology. Single center series in complex endovascular surgery for complex aortas or even regular EVARs. But I will present the first data on using this technique in occlusive disease. And you can use this for navigation, recanalization, and for re-entry. This is a case which was planned for a CIRAP, and this is my first patient case. It's a 73-year-old female with intermittent claudication. She has low ABIs, and her CT angiogram demonstrates aortic disease and common iliac disease. So we planned her for a CIRAP. This is just the way we do, like in EVAR planning, with a central luminal line and 3D reconstructions. And this is the image of the recanalization of the left common iliac using the LumiGuide wire and a forced Berenstein catheter. And using those rings, you can navigate very nicely through that stenosis. This is the other side, where we ended up crossover and then had to move the wire up into the aorta. So after that, we performed the CIRAP and then subsequently self-expanding stents in the external iliac. She did well, and this is her CT angiogram after a year. The next case is a 55-year-old male with rest pain on his left foot and claudication on his right foot, and he had previous kissing stents in the aortic bifurcation. And you can appreciate on the CT angiogram that there is an occluded stent on the left. So he was also planned for a CIRAP. And here is a video of how the guide wire is automatically registered using the LumiGuide technology. This is the stenotic side, which was easily to recannulate, and this is the occluded stent that we were able to pass with the same wire and catheter. After that, the aortic B graft was positioned in the aorta. And also the next maneuver, recanalizing the aortic B graft in the same way as we do a contralateral EVAR limb, is also possible again to do radiation-free using a force technology with a universal flush catheter. So this patient also did well, and this is his CT angiogram at 6 weeks. We have now done 18 cases with this technique, half male, half female. 14 were primary interventions and 4 were secondary interventions. 2/3 of them were claudicants. They had task B, C, but predominantly D lesions because we did the CIRAP in them, and they had quite some occlusions, 1 aortic occlusion and 4 iliac left and 6 on the right. This is, in all our CIRAP cases, the percentage that we usually do percutaneously is 2/3. So 1/3 of these patients need some kind of endarterectomy, either unilateral or bilateral. And there were some other concomitant procedures during these cases. We started the procedure bilateral with the LumiGuide guide wire in all of them. And in the first 10, we used the force catheter. This was before the 3D hub was available, and after the 3D hub became available, we could use any catheter, and then we use a universal flush for stenosis and a pier catheter for an occlusion. We had to disembark with this technique 4 times. So one case was a bilateral iliac occlusion, where we did a remote endarterectomy, Professor Moll first, and then we were not able to retrograde, recanalize this, and had to convert to arm axis, and that is not possible with the LumiGuide because you have to attach it to the table on the lower side. You have to choose beforehand if you go via the arm or the leg, but you can't convert afterwards. We were not able to retrogradely recanalize 1 aortic occlusion and convert it to another glide wire. There was another unilateral occlusion that we were not able to recanalize and had to convert. And this is the 4th failure where we could not achieve a proper re-entry. And this is the example. So this looks very nice. When I'm trying to recanalize the right common iliac and the wire goes up into the aorta, you would say. But then I didn't really trust the next image on the right, where you can see that the catheter makes this odd bend, And I didn't believe we could have a safe re-entry in the distal aorta to perform a CRAP. So then we disembarked and moved to a contralateral approach with a regular technique using a glide wire and a universal flush catheter, which worked well, and then finished the case. So there was 100% technical success. This is not LumiGuide success, but technical success of the CRAPs. We didn't have any mortality. We had one complication with the bleeding, treated with a covered stent, and patients stayed in the hospital for 2 days. And these are the fluoro times, which is an average of 16 minutes fluoro time. Next slide. Let's see if it works. Can we progress to the next? Mean follow-up of this cohort is 21 months without mortality, with a clear improvement in ABI and in the Rutherford classification. Imaging follow-up shows us that there is a primary patency of 83% and a secondary patency of 94% after around average 2 years. So the LumiGuide system, powered by Force, can successfully navigate in CRAP procedures through stenosis and also recanalize stenotic or occluded stents. Recanalization of aortoiliac CTOs and aortic re-entry can sometimes be challenging, but it's feasible with this technique without radiation in more than half of the cases. The guide wire properties are innovated regularly by Philips, so this will definitely improve the success rate. And these are the first steps towards radiation-free endovascular aortoiliac occlusive disease treatment. Thank you very much, ladies and gentlemen.
Have I any questions, Queen?
Sorry, I'm always the guy asking the questions. Is there, probably not appropriate in this session, but in terms of using this technology for lower extremity interventions, what's your experience, and is there a limitation on the size of the catheter? Can you mount this on a 14 wire?
We have very limited experience with lower limb treatments with this technique. I know that in Professor Moll's hospital, they've done some, because there's a case report in literature on an SFA case. So, but it shouldn't be a problem. It's an 035 system. Navigating through stenosis is actually is easy. Should not be any problem. Lower limb, upper limb, wherever. Really recanalizing, or for example, going subintimal is not possible, because the guide wire is, the first bit of the guide wire is very floppy, and then it becomes a bit more stiff because of the fiber optics inside. So you can't make a loop, for example. So that's a restriction. It's not able to make a loop, and it has the Terumo properties, but it's not as good yet as our workhorse Terumo wire. So really giving you enough power to go through an occlusion is different. So the wire needs to be optimized a bit more, I think, for some techniques. And it's 035, so you need an 035 catheter, but you can use any catheter you want. So there's also, the wire now is 110 centimeters, which is a restriction if you have a long catheter. Like, you cannot use a 125 catheter. But the wires that you have in the US, which come to Europe soon, are 1.60 meters, so that's going to get better.
Please.
Yeah, I have a question. Thank you for your excellent presentation. It's a very good technique, I think. But I have a question. In some cases, example for the complicated cases, for example, the totally occluded iliac artery lesions, I think maybe sometimes the picture is not as the same as the DSA. Maybe there's a risk of the rupture or bleeding, and how to prevent this complication, for example, the rupture. Do you think some endovascular vision technique, for example, IVUS, is helpful? Thank you.
So I'm not sure if these questions relate to the LumiGuide technology, but I agree that with complex lesions like iliac CTOs, there's a risk of rupture if there's a high calcium load. The way how we deal with that is to have all our covered stents ready to use when they are necessary. I think everybody would have the same approach. IVUS is probably helpful in some cases to see your residual stenosis rates, but we don't use IVUS regularly for aortoiliac occlusive disease, more for aortic dissection cases or lower limb.
Okay,
but you image it at the end to see the result of your treatment? Are you still using radiation for...
Yeah. So this is a tool for now only
for
to
crossing.
use navigation, crossing, re-entry. But the stents, placement of stents or control angiograms, you still need radiation.
Yeah. So, I mean...
Yeah, sorry.
Okay.
Well, you're running off a fusion image from a pre-op CT?
Yes, so within the LumiGuide system, it works just as fusion. So it's quite helpful. In these cases, what I didn't show is it's very helpful to have two planes without having to move the II. So this is one of the advances of force. Not necessarily in aortoiliac disease occlusion, because you know where to find your way, but especially in complex aortic cases. I'll show in the afternoon, where you have to, for example, go to fenestrations. You avoid lateral X-ray for SMA cannulations, etc., because you have the two-directional imaging biplane.
Dr. Stu.
Thank you, Professor. It's very impressive. We did not have this technique, but I want to know what are the potential risks of this new technique instead of the traditional imaging methods?
So the risks are, I think, where we've seen things go differently is when the guide wire properties, for example, the guide wire can be a bit stiffer. So when you perforate, for example, a vessel, which you would never do with the Terumo, we've seen some issues occasionally in renal arteries in fenestrated cases with stenosis, where we weren't sure if the wire was nicely passing through like we would have with the Terumo, and that's the major risk that we've seen so far. So technical or material problems. Yeah.
Okay, thank you.
But I haven't seen that often, actually. No.
Okay. Yeah.
We can have
there any?
discussions.
Okay. Maybe time is limited, so we will close this session. No? Okay.
We can do a panel.
Yeah.
Yes.
I actually have one more question, maybe to Dr. Saracha. Now that we have IVL, we have plug modifying balloons, and do you think that we'll ever be stent light or stent free in the aortoiliac segment?
Yeah, I think the IVL will change the game of the calcium. So the stent rate, I believe that the stent rate in the aortoiliac will be decreased. Yeah.
And how about, we've got good results from aortoiliac stenting.
Right.
But putting a lot of hardware, so
Yeah.
if we do get luminal gain, will we still deal with the problem of noentymal hyperplasia, and is drug-coated balloons going to work? What do you think?
I agree with you that if we deal with the calcium, like we use the IVL and softening the plaque modification and softening the calcium, and stent rate may be decreased, and in the future we will not face with the in-stent occlusion or stent restenosis. Yeah.
So Stephen, I think, because it's a very good question, the most recent European guideline states, because looking at the evidence for stenting is not that large. We all put in stents. But the newest guideline says that you use a balloon angioplasty in the iliac system, and if you have a good result, You only do selective stenting. So the answer to the question is we can do without stenting if you have a good result of your balloon.
Yeah, but I mean, we still don't have we still injure the wall with shock wave or whatever you have, I mean, I'm just wondering, if we don't put the scaffold, is it a good thing, or are we going to get restenosis from vessel wall injury later
I
on?
think in general, we just don't know nearly enough about morphology of atherosclerosis, and that all of our endovascular techniques are limited because, we have blunt tools like a balloon or a drug-coated balloon or a lithotripsy balloon. But that doesn't really account for people who have nodular plaque with a cap of calcium versus people who have osteoid metaplasia and calcium throughout their media versus people with thrombotic atherosclerosis versus fatty atherosclerosis. And we don't have treatments directed to any of those specific morphologies that are going to be durable. And so I think in the iliac system, because the vessels are bigger, you'll get some luminal gain with some of the technology that we do have, and that you can stent selectively. You will still have intimal hyperplasia and recurrence and, recoil of the elastic wall if there's still elastic wall left, but it won't be as detrimental as it is in a smaller blood vessel lower in the leg. So you may end up with adequate primary patency without a stent, but there's a lot of endovascular innovation that we still need to do to really get it more completely stent-free.
Yeah, I think, Stephen, good question that we need to tailor our stenting strategy. If you look at the gender differences in iliac sizes, especially for females with small external iliac arteries, if the lumen is 5 millimeters, are you going to put a stent into the external iliac? The patency rates for a small stent in external is very poor. So I think we just have to tailor our strategy and, even look at gender differences to see whether we should put a stent or not based on the size,
Another question I always have, just to be provocative, should we be doing, now that we're doing a lot of endo intervention, right, should we be doing more thromboembolectomy with devices to remove the thrombus before we slap in the stent? Because we do have occasional problems of the stuff flying off and spilling out into the renals and everything. Is there a role to remove that thrombus and clear the space before you put in the stent? I wonder what's the opinion of everybody. So maybe Sven, should we clear up the thrombus first?
If there's thrombus, and as Soracha already said, if you do this CTA in advance, then you can estimate if there's a lot of amount of thrombus. And if you see a lot of thrombus, then you should go and remove it with thrombectomy devices, because otherwise you are on risk for distal embolization, as well as maybe if you work in the aorta into the renal arteries. According to my experience, most of these aortoiliac diseases, a lot of calcium only, and I think debulking or atherectomy in these cases is not very effective.
Well, definitely good questions, and some of them will be answered in the next session probably, because we have another aortoiliac disease session with, for example, a lithotripsy talk. But I'm not convinced we need to debulk in the iliac system. I don't think there's any evidence yet, just as in the SFA region. But I'm not convinced, even though I do remote endarterectomies for the external iliac artery, because I think it's nice to debulk there. Potentially, the external is a bit different than the common.
A good option could also be truck-coated balloons. Any experience here from the panel? We have no data actually regarding this. Anybody who's using truck-coated balloon in the iliacs? The principle of work should also work in the iliac arteries. And maybe we can save stents here as well if you use truck-eluting balloons. But I myself, I also have no experience here in this field. There's no reimbursement in Germany for the application in the iliac arteries for DCB, so we don't use it there.
We would, if we choose a non-primary stenting approach, which is what we usually still do, even though the guidelines do not advocate that. But if we would choose for ballooning, then I think we would use a drug-coated balloon in the iliac arteries. Yeah. Please give some summaries. To give a summary for the session, that's a very nice task. I think I'll be very brief there because we are just at 10, so the time is up, and I think we enjoyed very much this first session, which had innovation, old school technology, open and endovascular techniques, early recovery. It had it all, but we have another aortoiliac disease session in half an hour after the break. I see Dr. Patel is already ready for that, giving a talk on the lithotripsy. I'd like to ask everyone back in half an hour, after the massage.